Ladies and gentlemen, esteemed guests, and fellow healthcare professionals, welcome to day 4 of the second OncoConnect Global Summit. I am Dr. Harshita, your host, and today promises to be just as enlightening as previous days. Before we delve into engaging discussions and presentations lined up for today, let's revisit the core mission and goals of this summit. Our mission here is to foster collaboration, share knowledge, and advance the field of oncology. We believe that through collective efforts and the exchange of ideas, we can make significant strides in cancer care and research. We have had 3 incredible days of this event so far, and we are excited to continue the journey. The insightful discussions and knowledge exchange and collaborative spirits have made these days truly exceptional. Today, we look forward to another day filled with enriching insights and engaging conversation. Let's carry this momentum forward and make today's session just as remarkable as previous ones. For our first session today, we have with us Dr. Suhas Kirti Singla, a medical oncologist and a consultant and head at Positron Multi-Speciality and Cancer Hospital, Rohtak. Dr. Suhas will share his valuable insights into the recent advances in immuno-oncology for the effective management of colorectal cancer. It's a pleasure to have you here with us today, Dr. Suhas, and thank you for dedicating your time to share your valuable insights with the MedSynapse medical community. A warm welcome.
Thank you.
And for our audience, we encourage you to post your questions in the comment section. We will try and address all of them at the end of the session. So without any further ado, let's get started. Over to you, Dr. Suhas.
Thank you, Dr. Harshita. It's a great platform to share my views on one of the very burning topics, that is colorectal cancer. So not without any much ado, let's start with the topic, that is the role of immunotherapy in management of metastatic colorectal cancer. Though the trials are being going on for role of immuno-oncology in patients with stage 3 colorectal cancer also, but yet the role has very well been defined and is still being defined in metastatic colorectal cancer. So to start with, colorectal cancer, to start an overview, incidence and the prevalence, it is the third most common cancer with 1.9 million cases worldwide as per 2020 data. And it is the second most common cancer cause of cancer-related death with around 9 lakh deaths in 2020 itself. So epidemiology, it is higher in developed countries, but the incidence is on rise in developing countries too. Age more than 50 is highly significant, and that's why the screening program generally take the same into consideration. So what are the challenges in advanced colorectal cancer? The first thing is that it is a very heterogeneous disease, and the survival is less than 40% for 2 years. If we see at this graph, which is as per the AJCC 7th edition, so it is not a very good curve to be seen, with around 40% even at 12 months, and the graph continues to fall. So what are the different pathways of colorectal cancer which result in its heterogeneity? And the one is the chromosomal instability or the proficient mismatch repair or microsatellite stable diseases. And the 15% of them approximately account for the microsatellite unstable disease or a deficient mismatch repair disease, of which 2/3 are sporadic and 1/3 are familial. So resulting from Lynch syndrome, which is in germline mutation in MLH1, MSH2, MSH6, or PMS2. These are all the MMRGs. So coming on to the treatment stratification by molecular subgroups, the molecular subgroups in CRC are shown in this pie chart, and most of them are actually either RAS mutated or have MSI high, BRAF mutated, HER2 mutated, and TRK, and many other anecdotal reports are there on trials in pre-treated patients. So this cartoon actually shows the evolution of therapies in colorectal cancer, starting from 2004 when anti-EGFR agent cetuximab was introduced, later on panitumab in 2006, in between bevacizumab, and later on other anti-VEGF inhibitors were immune checkpoint biomarkers used for immune checkpoint inhibitors in colorectal cancer. This is one of the very important topics because many of them are coming up, of them have been rejected. So few of them I have mentioned over here. So MSI high or deficient MMR, that is microsatellite instability high or deficient mismatch repair genes. This is the most acceptable biomarker of response with a prevalence of around 20%, but in totality, but less than 5% in stage 4 colorectal cancer. Methods of detection include IHC, PCR, or NGS. Mechanism still remains to be unclear, but in presence of so much of microsatellite instability, possibly a higher tumor mutational burden is the cause of higher number of new antigens, thus resulting in a better performance of ICIs. Overall response rate range from 30 to 70% in patients who are positive for MSI or MSI high or deficient MMR. Another which is there is tumor mutational burden, and total number of somatic mutations detected per million basis is the way to actually detect the tumor mutation burden. Higher the TMB, which is associated with higher number of neoantigen, resulting in a higher immune reaction. TMB of more than 8 mutations per megabase are being found to be associated with a longer OS in various studies. In a Canadian cancer trial group, that is CO26 study, in even MSS colon cancers, that is microsatellite stable colon cancers, durvalumab with tremelimumab were associated with elevated plasma levels of TMB with more than 28 mutations per megabase pair, which correlated with a better survival. But the drawback is that more than 10 mutation per megabase pair has not been associated with survival in all the CRC patients. So yet the baseline that where we have to look for example, our TMB of more than 10 have been associated with a good survival in lung cancer, but it is not associated with the same. It has not replicated in the similar fashion in colorectal patients. So in such a scenario, we still have to find out the ROC curve for TMB in colorectal cancer patients. Another is the consensus molecular subtype. So this is the main thing where MSI related immune subsystem subtype of CMS1, where the overall response rates have been to the tune of 100%. When studied, overall response rates for CMS4, that is this subgroup, has also been around 16%. But in patients with canonical subtype or the metabolic subtype, that is CMS2 and CMS3, the response rates have been up to the have not been very great and have been to the tune of 0%. Another is tumor infiltrating lymphocytes, which we have talked earlier also. So they have been found to have a prognostic significance in various studies. In an analysis, a separate analysis of Keynote 177 trial, response was associated with TILs rather than TMB in patients who harbored CD8 positive PD-L1 positive T cells, and this was associated with a higher response. For microsatellite stable patients, higher CD8 positive TIL density results in a benefit from immunotherapy. Drawback, there is no standardized methodology to detect the same. Another way is the immunoscore, quantification of CD3 positive T cells and CD8 positive T cells at the tumor center. Now it uses IHC, scoring is IS0 to IS4. Drawback is it is a semi-quantitative method based on IHC only and is yet not standardized. Another one is circulating tumor DNA, the famous liquid biopsies. Derived from apoptotic and necrotic tumor cells can be used to predict responses. It's a powerful tool predicting microsatellite stable colorectal cancer patients' response to regorafenib and nivolumab combination therapy, which was actually done and was published in Annals of Oncology under the header of Journal of European Society of Medical Oncology. Another CAVE trial where KRAS, NRAS, BRAF, EGFR mutation were analyzed through ctDNA. Response to cetuximab and nivolumab were higher in patients who had RAS or BRAF wild type ctDNA and were associated with a better OS and PFS. But again, the drawback is there is no phase 3 data available. There is no standardized methodology for the same. Now, as till now, what we have come across is that all the biomarkers are available, but MSI or the MMR are the most standard ones. So let's go through the algorithm for understanding what is it and how it has to be done. So in any colorectal surgical specimen or any biopsy for that matter, IHC testing for MLH1, PMS2, MS6, and MSS6 and MSH2 has to be done. In patients who have an indeterminate IHC, MSI testing is done, and if it is found to be MSI low or MSI stable, then there is no further testing required. If MSI is high, then the patient is to be referred to a genetic counseling for consultation of germline mutational analysis. In the same way, if the patient has been analyzed with NGS and the patient is found to have a loss of other MMR proteins, then also patient is to be referred to a genetic counselor. Loss of MLH1 and PMS2 is a special group, as an analysis of BRAF V600 E is to be done, because MLH1 promoter hypermethylation can be caused by the mutated BRAF V600E mutation. If it is present, then no further testing is required, and the tumor is actually MSI high because of the BRAF V600E positive mutation. And in absence, the patient is to be considered for genetic counseling. That means that the patient is having a germline mutation. So as we have come across all the biomarkers, general treatment algorithm for a metastatic CRC, when we talk about MSI high or deficient MMR, one must consider a PDL1 inhibitor with or without a CTLA4 inhibitor, or a chemotherapy with targeted therapy, as with BRAF and RAS wild type tumors. And in second line, also, if the patient has not received any PDL1 inhibitor, then PDL1 inhibitor with CTLA4 inhibitor, otherwise chemotherapy with targeted therapy, remains a treatment of choice in patients with BRAF or RAS wild type. In patients who do have RAS mutation or BRAF mutation, there the only option available is chemotherapy. So approved checkpoint inhibitors in metastatic CRC are pembrolizumab, nivolumab with ipilimumab. So as we see, it's anti-PD1 or anti-PD1 with a CTLA4. So these are the ESMO guidelines, where it is very much clearly shown that patients who have DMMR or MSI high, pembrolizumab is the first category 1 therapy to be available. So what is that which has resulted in approval of pembrolizumab is the Keynote 177, a phase 2 randomized, a phase 3 open label randomized trial, where 307 patients were randomized to pembrolizumab versus chemotherapy until progressive disease, intolerable toxicity, or patient withdrawal. Chemotherapy options included FOLFOX6 as a standard, or FOLFIRI plus minus bevacizumab or cetuximab, depending upon the RAS status, and crossover was permitted at disease progression. There were dual and primary endpoints, that is PFS and OS, and the one of the things which was done for the same was analysis of the PFS2 and HR health related quality of life analysis in these patients. So the baseline characters were very well matched, and then if we come on to the results, so though the graph seemed to have actually been in a lot, having created a lot of difference, but this kissing of the graph and then crossing over actually makes the data a bit hazy kind of. So here obviously the events of progression have been only 54 with pembrolizumab, 73 with chemotherapy. The hazard ratio has been blooping of 0.6 with a great p-value, and the median PFS has also been almost doubled with the use of pembrolizumab. But initially, the patients may not have very good response. It actually picks up after the utilization for at least 6 months. So one has to be very clear that these patients may not respond initially and may progress very soon in early times. So we have to understand that it is a possibility that we may have to combine chemotherapy with immunotherapy for better results. Even when we talk about the PFS2, the data is very good with a median PFS which has not reached for pembrolizumab and is only 23.5 months for chemotherapy. So final overall survival analysis, again the data, again the graphs are kissing and crossing. So this is not a very brilliant data, but yes, it is one of the best in immuno-oncology. So again, median OS has not reached for such a long follow-up, and it is 36.7 for the patients receiving chemotherapy. If we talk about the CR rates were also higher when we see in patients with pembrolizumab, and partial responses were also a bit higher, though the stable disease was much higher with chemotherapy. Subgroup analysis, most of them benefited, but all of the subgroups actually the line crossed the line of unity. So there is no significant difference amongst the subgroups. So when, as we already mentioned about the health related quality of life, when we talk about the social functioning and fatigue, it was much better in patients receiving pembrolizumab over chemotherapy. So median time of deterioration was longer with pembrolizumab versus chemotherapy for quality of life analysis. So if we talk about the adverse events, sorry, grade 3 adverse events were much higher, almost to the tune of 3 times in patients receiving chemotherapy. And this is very true. So in conclusion, if we talk about in patients with MSI or DMMR, first-line pembrolizumab demonstrated a significant improvement in PFS as compared with chemotherapy and had a manageable safety profile. Another trial is Checkmate 142, nivolumab plus minus ipilimumab in patients with MSI high or DMMR metastatic colorectal cancer with a 5-year follow-up. It was a phase 2 non-randomized trial. Now, over here, we could only show the 2 arms of the same, but it actually had 3 arms, nivolumab versus nivolumab in second line, nivolumab with low-dose ipilimumab in second line versus nivolumab with low-dose ipilimumab in first line. So primary endpoint was overall response, secondary endpoint was BIR-CR analysis. So again, if we see the data is almost balanced in the distribution, and then we come on to the outcomes. So overall response rates were best if we talk about in percentage with the patients who received nivo-ipi in first line. And the CR rates were also better with nivo-ipi in first line, and PR rates were also better in patients receiving nivo-ipi in first line. Though, if we talk about the disease control rates, then the difference was not very significant whether they receive in first line or second line. Now, looking at onto the graph of the same, if we talk about extended follow PFS, if we see that the PFS has median PFS has not been reached for cohort 2 as well as cohort 3. So that means that using it the same in either using nivo-ipi in first or second line is not going to change the analysis. Similarly, if we talk about OS, the data are again favoring the nivo-ipi whether in first or second, but they can be used in any of the lines of therapy. Subgroup analysis, the subgroup analysis now shows that using nivo-ipi is much better in patients who are less than 65 in first line and is equivalent in patients if they receive the same in second line. And the for the BRAF mutant, patients receiving nivo-ipi in first line, they respond much better as compared KRAS mutant and in patients with BRAF mutant. So in patients who have BRAF mutated but have MSI high or have deficient MMR, one can consider nivo-ipi in first line therapy. So Checkmate 142 extended follow-up, treatment status and treatment-free interval if we talk about. So treatment median follow-up was maximum for the patients receiving nivolumab, and deaths were also maximum in the patient receiving nivolumab. Patient alive were maximum in the patients receiving nivo-ipi in first line, followed by nivo-ipi in second line, followed by nivo-ipi in nivo in first line. So, and if talk about the adverse events were almost similar in all the cohorts. So to conclude, in an extended follow-up of 5-year, durable clinical benefit and safety was observed for patients with MSI high or deficient MMR, metastatic CRC receiving nivolumab plus minus ipilimumab. Overall response rates were 39%, 65%, and 71% for second line and beyond nivo immunotherapy, second line and beyond nivo EP, and first line nivo EP. No new safety signals were identified. Investigators concluded that these data support current treatment recommendation for both first and second line and beyond treatment with Nivo EP for patients with MSI high or MMR metastatic colorectal cancer. A phase 3 checkmate 8WH trial with Nivo EP plus minus EP versus investigator choice chemotherapy is ongoing. Another trial with anti-PD-L1, that is atezolizumab, was undertaken, and it was named as AtezoTribe. It was for unresectable metastatic colorectal cancer, treatment naive, ECOG performance status less than 2, with total number of patients of 218, and the patients were randomized into 2:1 ratio with atezo with folfoxiri with bevacizumab 8 cycles, followed by atezo with bevacizumab with 5-FU leucovorin, that is without oxaliplatin and irinotecan, and the other group was folfoxiri with bevacizumab for 8 cycles, followed by bevacizumab with 5-FU leucovorin. And this was followed by reintroduction of folfoxiri with bevacizumab plus minus atezolizumab, and then bevacizumab with 5-FU leucovorin with or without atezolizumab. Primary endpoint was PFS. This is one of the drawbacks of the study. In patients who are already unresectable metastatic colorectal cancer, I think primary endpoint should be OS rather than PFS. Secondary endpoints were response, resection rate, and safety. So updated PFS in intention to treat population, PFS was found to be very much improved with a highly significant p-value where the hazard ratios were 0.71, that is a 29% reduction with the addition of atezo to the TRIBE trial actually. Folfoxiri plus bevacizumab was the baseline treatment of TRIBE trial, and the addition of the same resulted in atezo TRIBE trial. In a multivariate analysis, significant interaction was found between PFS and treatment in specific biomarker defined subgroup favoring atezolizumab addition in immunologically active tumors. That is, when stratified with MMR status or TMB or immunoscore, it was found to be beneficial to add atezolizumab. And if we talk about the OS was not very significantly different in the two arms. In patients with proficient mismatch repair genes, the difference was again not statistically significant. Though, if we talk about the subgroup analysis in patients with immunologically active tumor, atezo was found to be favored, with patients having high TMB and immunoscore of 1C was found to be better. And if we talk about the OS, again, OS was not statistically significant, but the favorism for atezolizumab was maintained in the immunologically active tumors. So atezo-tribe outcome by treatment and immunoscore, if we look at the data and if we look at the graphs, if we look at the curves, it has been found that patients having higher immunoscores were found to have a better outcome with addition of atezolizumab, and thus with a hazard ratio for PFS being 0.47 and hazard ratio for OS being 0.4. So folfoxiri plus bevacizumab plus atezolizumab versus this randomized atezo-tribe study by Gono. This is the main response rates which we can see. The p-values were not very significant. So finally, to conclude, I'll say that the patients with unresectable metastatic CRC, first-line atezolizumab with folfoxiri with bevacizumab demonstrated a significant improvement in PFS over folfoxiri plus bevacizumab and was generally well tolerated without any significant difference in OS. So The investigators concluded extended follow-up confirms that addition of atezo to folfoxirif plus bev has initial therapy prolongs PFS in patients with molecularly unselected metastatic CRC, and there was a trend towards prolonged OS observed, though it was not statistically significant. There was a trend of benefit in patients who have proficient MMR with the PFS and OS being 0.79 and 0.83, but they were not statistically significant. Tumor mutational burden and immunoscore high subgroup showed increased benefit. There is a planned phase 3 trial which is required to evaluate the addition of atezolizumab to follicular plus bevacizumab as initial therapy in patients with proficient MMR in metastatic CRC and immunoscore of 1C high disease. Other two trials, which were COMET and FOLFOX, also tried atezolizumab, but there was no significant improvement. ESMO guidelines have now updated utilization of nivo-ipi from CheckMate 142 trial, and they also suggest to utilize the same in second line, especially for patients who are deficient in MMR or have MSI high. So another extended follow-up of CheckMate 142, where only the patients who received nivo-ipi in second line therapy, followed by nivolumab maintenance. So primary endpoint was ORR, and this data was read at ESMO by Andre et al. And has been published in Annals of Oncology in 2021. So the median PFS was not reached with utilization of nivo-ipi in second line, whereas the overall survival has yet also not been reached. So this shows that it is very effective when utilized in second line or beyond the second line. And if we look at the further data analysis, the overall response rates were huge, with a 65% response rate with utilization of nivo with ipi in second line and beyond. And the rates of complete response were also good, partial response being 52%, which is very high. And then if we talk about the grade 3-4 side effects, so grade 3-4 side effects were seen in 32% of patients, and of which 20 were very serious, and most of the patients actually developed hepatic side effects, which include most of the time transaminitis and sometimes rising bilirubin. Acute fulminant hepatic failure was also seen with this therapy. So in a previously treated patients with MSI high or dMMR metastatic colorectal cancer, nivo plus EP demonstrated a durable clinical and survival benefit with a manageable safety profile. Keynote 164 is another study where pembro monotherapy was used in advanced MSI high colorectal cancers, long-term follow-up of a phase 2 trial. And in this, there were two cohorts where it was utilized in patients who have received more than 2 lines of therapy, or in those who have received more than, or those who are receiving in second line of therapy. So the best results were observed in patients who received it in second line, with an overall response rate of 34.9 versus 32.8 in cohort A. Median PFS was again 4.1 months, and the 3-year PFS rate was 34% in cohort B versus 2.3 months in cohort A, and the 3-year PFS rate being 31%. Median OS has yet not reached for those using in second line, and the 3-year OS rate being 52%. So pembrolizumab continues to provide an effective long-term anti-tumor immunity with durable responses with small number of drug-related adverse events and no drug-related deaths in patients with advanced MSI high colorectal cancers. So there has been trials going on to actually turn the cold tumors into hot tumors. What do we mean by that? That is, those who are not liable to respond to immunotherapy we want them to respond to immunotherapy by making them hot. So IM Blaze was one trial where it was a negative trial where atezolizumab and cobimetinib were used against regorafenib. And another trial was regorafenib with nivolumab, and results have not held up in subsequent studies. LEAP 005, where pembrolizumab and lenvatinib have been used, though early, but the results are interesting. These are the data from LEAP trial, but the studies results are yet to be published. There are many important ongoing trials where pembrolizumab is being used alone or in combination with bevacizumab, or nivolumab is being used in combination with ecorofinib or binatinib, and the data and the name of the drugs and the combination goes on. So I think coming up years will see a boom of immuno-oncology in colorectal cancers and will result in better survival with a very great safety profile, as they are associated with minimal side effects and better quality of life, especially which is required in patients with metastatic diseases like colorectal cancer. So with this, I conclude. Thank you. Any questions are most welcome.
Yes, Doctor. So thank you, Dr. Suhas. Your session was highly informative, and I'm confident that our audience has gained valuable insights. And we do have a couple of questions from our viewers that we would like you to address. So the first question is, what criteria are used to identify patients who are most likely to benefit from immuno-oncology therapies?
So to date, the only thing which we have found to be most effective, as I have already told, is the MSI high tumors or those who are deficient in mismatch repair gene. These are the only two approved criteria which are being used in clinical practice for identifying those who can benefit. But in coming times, tumor mutation burden or immunoscore may be utilized later on.
And the second question is, what are the strategies employed to address resistance or relapse in patients undergoing immuno-oncology treatment?
So this is a very tricky point. So basically, it is like in patients who are receiving immunotherapy, they may have a phenomena called pseudoprogression. So there we have to be very careful that initially the tumor seems to have swollen up when a PET CT or a CT is done. And that has to be followed up for, with another imaging, mostly at interval of 6 weeks, just to understand whether the tumor is actually responding or not. The best way otherwise is to address such a thing is to re-biopsy the same and to understand that how the tumor is maturing or the tumor is actually necrosing. So we have to understand that, but generally clinicians do avoid doing the biopsy in such a scenario because that becomes a bit more cumbersome. So that's why the best way to understand the same is to look at a 6-week scan and to understand how the tumor is responding.
Yes, thank you, Dr. Suhas, for answering our audience's questions. And your expertise has truly enriched our session today. Thank you for your valuable contributions.
Thank you.
And also, I would like to thank our audience on behalf of MedSynapse for participating. Thank you.